Yeah, it's coming there now. Perfect. Great. I'm going to stop talking then and hand over to you. Thanks, Leo.
Thanks very much, Michelle. So welcome everyone to this session entitled Perspectives on Clinical Education. So just to give you a little bit of a background about what I'm going to be discussing, I'm going to focus, as Michelle said, on the areas of simulation-based education in healthcare, and in particular, debriefing that we can do with students and learners following simulation and engagement in clinical skills. From there, I'm just going to move on to talk a little bit about how we can give effective feedback in the clinical environment, and in particular, the models and approaches that we might use to give that feedback and how we can make it most effective for students learning. And finally, what I'd like to do is just discuss a little bit about how we can instill resilience in our graduating practitioners and in student radiation therapists, and how we can do this by promoting empathy and empathetic practice when students are training. So before I go through those topics, I'd like to just give a little bit of context, because a lot of the themes and ideas which I'm going to be mentioning really fit in to the clinical practice module here at Trinity. And hopefully, as I go through these topics, they won't just be applicable to if you're training Trinity radiation therapy students or radiation therapy students at all, but in any situation where you're providing learning, you're supervising clinical skills, hopefully the topics that I'm discussing will be useful. That said, to give a brief overview of what a typical clinical placement looks like for our undergraduate Trinity RT students here. So students attend placement throughout all 4 years of the undergraduate course here at Trinity. And the typical placement block is broken up into 3 to 5 week lengths. So here you can see that in a typical 4-week block, throughout the actual placement itself, there is regular formalized feedback that students are given. But as anyone who has supervised in the clinical environment knows, students are constantly being assessed and provided with feedback when they're in the clinical environment. And one of the big main concepts of clinical placement is, in general, is that we want students to be able to build on their academic learning to gain the attributes required to be a qualified practitioner, a well-rounded practitioner, and we want them to do this through engagement in clinical skills in the actual live clinical environment itself. And for us in the radiation therapy environment, this means that when our students graduate, they're able to meet the core standards of proficiency at the very end of their final clinical placement in their 4th year and on graduating. However, when engaging in a clinical environment, there are large barriers for students. And one of the main barriers for students when they're trying to engage with key clinical skills is that the prospect of carrying out tasks on live patients for the first time is highly intimidating. The environment they're carrying out these tasks in are often busy, there's distractions, and the clinical environment can often be quite hectic, and this can mean that students' ability to gain tasks in a controlled way is diminished. So in order for us to help us bridge this gap from students having academic knowledge to being able to complete tasks under pressure in a proficient way, what we can do is introduce simulation. So simulation allows students to participate in clinical tasks in a risk-free environment that's controlled and that they might not be able to participate in clinical placement otherwise. It also allows students to prepare for clinical tasks in a controlled way so that when they do go and set up real patients, attempt whatever task it may be, they're not just prepared, but they've also been fed forward to by their clinical supervising staff and those preparing them. And just to give a little bit of background on the concept of simulation in healthcare, so a very quick definition: simulation is any recreation of a real-world environment and real-world task in the clinical environment, which allows us to practice the skills required in that real-world scenario. And historically, this has mainly been a concept in medical education. So this is not just going back sort of decades, but now hundreds and even thousands of years. The oldest reference I found to simulation-based education in healthcare actually went back to 800 BC. But in recent years, simulation has grown with the proliferation of technology, with new and improved software, but also things like more and more advanced mannequins and dummies. What we've seen is that simulation has become a central pedagogical approach in healthcare education. And my own interest in this was piqued when I was lucky enough to attend the simulation-based medical education train the trainer session held here in TCD. What you can see here is the simulation high fidelity lab. And I was able to go for a day and receive training on how to create effective simulations for undergraduate students. And I myself was asked to participate in the simulation of an inpatient on a ward, quickly deteriorating and needing urgent medical care and assistance in being transferred to the ICU. And what I was asked to do initially in this simulation was assess if the patient required intubation, to which I replied no, because I've never had any training in that area. Then I was asked if I could draw up 30 milligrams of insulin and administer them to the patient. And again, I said, no, I haven't had any training in that area. And as the task went on, what I was asked to participate in eventually was honed into areas that I was actually able to participate in and help the other members of the team in that task. And what I found over the 10 or 15 minutes of participating in this simulation was that it didn't just recreate the environment of a hospital, of an inpatient ward. It didn't just recreate the equipment being used or even the situation that we were placed in. What it helped recreate was the real world pressures and urgency of that simulation as well. So I very quickly got to see how effective simulation can be in healthcare-based education. And what I realized over the course of the day was that it wasn't actually the equipment, the technology, the resources that made the simulations that we were being shown and asked to participate in effective. It was actually the principles that were being applied to those simulations. So I won't go through all of these individually, but as you can see, there are core concepts which, whether we're doing something very highly designed, such as the simulation I was describing, where there was an unwell patient being transferred to the ICU, or whether we're just doing something very simple, like a 5 or 10 minute role play, as long as we apply some simple principles, the simulation will be effective. And what I want to do is just apply some of these principles to radiation therapy. So you can see that whenever you're in a situation with a learner, you're able to implement a simulation, which, like I say, can be quite straightforward and simple, but have it really gain and allow students and learners to build on their clinical skills. And just some of these I wanted to point out. When you're designing a simulation, if you're able to provide an appropriate level of what's called fidelity, which is the degree of realism to the simulation, then you can really impact how effective it's going to be. So if you're able to provide realistic equipment, a realistic setting, that's really going to aid how effective a simulation can be. The next thing is to make sure that we're engaging in deliberate practice. And that means having motivated and engaged learners and students. Now, we can't always provide students with engagement, but what we can do is provide students with knowledge of what we're aiming to achieve with a simulation and what the outcomes are. Whenever we are creating a simulation, what we want to do is make sure that the task being attempted is vital for the clinical skills required for that discipline. And we want to make sure that it's providing students with an opportunity to practice tasks that they might not otherwise in the clinical environment be able to attempt. The tasks should always reflect the core learnings and the core skills required of a radiation therapist or whatever discipline the learner is engaging in. And finally, students should always be given feedback following an attempt at any task in a simulation. And if we can just do those 5 things in radiation therapy, then whatever the simulation is that we're designing will be effective. And I wanted to just give some examples of not just simulation that we provide students with here in the academic setting, but some possible examples of simulations you can carry out in the clinical environment without much preparation. So in the students' first year, we get them to carry out mask making sessions using each other's role-playing as patients. Similarly to this, we will take students into the clinical departments, likely to be over at St James here in Dublin. And what we will do is we'll give them time on a treatment unit to act as an RT team, simulating treatment setups likely on each other and problem solving within those setups. Here in the discipline itself, we have a system known as VERT, which allows us to replicate the conditions of a linear accelerator. It allows us to put a patient on the bed, and it allows students to use the controls of the LINAC to actually set up patients and go through the setup process. And lastly, what we get students to do in the discipline is we get them to do image review and IGRT practice on simulated patients in the discipline. And in the clinical setting, there are very simple things that you can do to allow students to simulate the clinical skills required over the course of a clinical placement. So phantoms can be used to simulate patient setups, and a phantom really can be anything. It doesn't have to be a dummy or a mannequin. It can be any 3D objects, which really you can put a reference mark on. First day consultations with RT role-playing as patients is one very common, simple simulation which can be done in the clinical environment. Even something such as a quick Q&A with a student, even while treatment is being delivered based on problem solving or potential actions they might need to take, would still be classed as simulation-based education. And lastly, offline image review with a supervising RT can really replicate online image review in radiation therapy itself. That said, even with those opportunities for simulation in the clinical environment, as radiation therapists, we are aware that most of the time that students and learners attempt clinical skills for the first time, it's highly likely that it's going to be on a real-life patient in a supervised setting. However, we can still utilize the principles of effective simulation-based education to frame these real-world activities and tasks. So with regards to these principles, the fidelity of the tasks that students are attempting, if they're attempting them on real-world patients, always we know the fidelity is going to be high. And all we need to do then is make sure that students are understanding the tasks that they are being asked to carry out and how they connect to their learning outcomes and to their development as RT. We want to make sure that whenever we're asking students to attempt a task on a real-life patient, we want it to be able to be transferred to their practice. So an example of this would be if a student is rotated to a pre-treatment unit and several times a day they're seeing patients be cannulated. That is a very good skill for RTs to have, but actually for students graduating, it's not one of their core skills that they need to pass the pre-treatment placement and to graduate as an RT. And we feel that actually there is more effective use of their time that can be made when they're on placement in pre-treatment, because the transfer to practice is higher than if they were learning cannulation skills in that environment. And lastly, as I was saying before, whenever students or learners attempt a task in the clinical environment, whether it be simulated or on a real patient, they should always be given feedback and they should always be given a debrief following their attempt. And I wanted to just talk about the importance of debriefing whenever a clinical task has been attempted. So Debriefing is a key portion of simulation-based learning. And actually, the research shows that where students and learners are attempting tasks, it's better to take time away from the task and the activity they're attempting than to remove the debrief altogether. And in addition to this, even, research has shown that the debrief is often as, if not more important than the task being attempted itself. And in line with this, any debriefing conversation that happens following a student or learner attempting a task should happen as soon as possible after the completion of the task. And when it comes to debriefing, currently, with the expansion in the role of simulation-based education in healthcare, there are a lot of models and there are a lot of approaches which can be taken to giving debriefing conversations and to guiding the learner in actually debriefing themselves from their attempt and from their learning. This model here is known as the PEARLS model. As you can see, there's quite an involved script and model which can be followed, but really in the RT environment, when you're discussing an attempt that a student has made at a clinical task, you don't need to remember all of these steps to this debriefing model. Really, you just need to focus on 4 key areas to make sure that the student is able to learn from and reflect on that task as effectively as possible. And these areas are: 1, always allow initially the participant to just have their reaction to the task that they've attempted. So they may say, actually, I think that went really poorly, or they may point out things to them which you wouldn't have expected. Whatever they bring to the discussion initially is likely to highlight the areas which are key to them. And that's likely to highlight any barriers to learning. It's likely to highlight any learning styles, which can then be incorporated into the rest of the conversation. It's really important that when we're having these conversations with learners, we're making sure that we're restating the focus of the simulation and task, and we're not getting distracted by other things which may have been occurring during the task or other events which may have happened. So we really want to focus on the key outcomes and key areas of the simulation or task that was being attempted. The next thing we do is when we're analysing the task in this feedback discussion, which may only be 3 to 5 minutes in length, we just want to make sure that the student is able to reflect on and analyse the event appropriately. So sometimes that can mean actually letting the student almost independently analyse the task. And that would be the instance, particularly in cases where the task has gone really well and the performance has been to a really high level. In situations where maybe there is a bit of a gap between the student performance and what is required, what we might need then is to guide the student a bit more in the areas that we need them to focus on the next time they attempt the task. And where there is a large gap between what is expected of the student and either their skill level or their knowledge level, what is required is often that we're outright stating to them what they need to improve on next time and what they need to concentrate on. But anything above this, we should be including the student in the discussion. And finally, before we close the discussion, when we're giving feedback and when we're debriefing, we want to just provide a summary of the event and an action plan for the next time it's attempted. So with all that said, what I wanted to do was just provide a very simple, concrete example in radiation therapy of a simulation that we can provide to students in the clinical environment, which is going to help with their learning and which is going to follow the principles of effective simulation-based education, which I've been discussing. So here, as you can see, it's a very simple example, a first day consultation where a student is asked to take the first day consultation itself, and the supervising RT acts as the patient. The student is prepared in advance with the details of the patient, such as the treatment site, their dose and fractionation, And as the consultation progresses, the RT will ask probing questions which don't just reflect a real-life patient's questions, but also probe the student's knowledge and their communication skills. And then after the consultation is finished, the RT will take some brief time to not only provide feedback, but discuss the student's reflection on the simulation and discuss strategies and adjustments which can be made when speaking to real patients. And here I've just pointed out that this follows all of the principles of effective simulation, which I've been discussing, and which are going to make this a really valuable learning experience for the patient. And from here, I just wanted to use this as a jumping off point for briefly discussing how we can provide effective feedback in the clinical environment. So just to briefly go back to our typical 4-week clinical placement, as I was mentioning, there are several opportunities where students are provided with formal feedback. And as we know, students are provided with continuous assessment and feedback throughout their placement. What we've really moved away from in recent years is a student attending placement for an extended period of time, and then either on the final day of their placement or sometimes even after the completion of their placement, being given some concrete feedback purely either in some brief words or just in the format of a grade. What we've moved towards now is more continuous feedback, and we've tried to change the way in which we give feedback so that when students receive this final summative feedback, ideally there wouldn't be any surprises in store for the student. At this point, it really should just be a summary of how they've performed and how they've taken on board the feedback that they've been given throughout the placement. And with regards to giving feedback to student itself, there are several models which are available, and sandwich model, for instance, is one which I'm sure that you've heard of, one where you will give the student some positive feedback. You will follow that up by telling them the negative things that they've been doing, the corrective feedback which you're required to give them, but then on the end of that, you give them some praise. And with feedback models such as this, historically, they haven't been based on as much evidence and as much clinical experience as we would like. So in recent years, what clinical feedback has moved towards has been away from, as I was saying, giving students a product at the end of their placement in the form of a grade, and feedback has been moved more to being thought of as a process. So continuous conversations that are being engaged with the student in. So we will be checking in with the student regularly, making sure that they're aware of their learning outcomes and making sure that they're aware of how they're working towards their learning outcomes. We've moved away from students simply being notified of the quality of their work, and we've moved more towards something that we describe as visibility. So the reasons for the students' work being of that quality. What is it that the students are doing that mean that the grade they're getting is not as high as they would like? What are the physical actions that they're taking, which are meaning that the feedback they're getting is at the level that it's getting at? And both of these things really encapsulate that feedback given to students has moved away from being a monologue where students are informed about their performance to moving more towards a dialogue, a two-way discussion where performance is discussed and action plans are created. And what we've moved away from is less to the use of simple 3 or 4 step models, as I was showing you previously, such as the sandwich model, and more towards a general approach to giving feedback, which encourages this continuous nature of two-way discussive feedback with students. So I won't go through all of these, but the key points that we want to get across are that the students should have very clear understanding of what they're being assessed on. They should be collaborating in understanding and creating their learning goals. And then they should be engaged in consistent and continuous feedback throughout the course of their placement. We want feedback to be as honest as possible, because as I was saying, the fundamental thing that we want to move towards is that when the student receives their overall grade for any clinical placement, there is no surprise there, and the student understands how they've worked towards that grade and why the grade is being ascribed to them at the level that they're at. Lastly, what I wanted to do was just discuss the context in which students attend clinical placement and how we can instill the attributes of both resilience and empathy in students, and why these are important for students to have when they graduate and when they're working clinically. So we know that when students go into the clinical environment itself is highly paced. It's an intense working environment, and the RTs require many different skills, and often these skills are required in ways which compete with each other. On top of this, students come in to the clinical environment in a situation where they're under constant assessment. Their grade relies on the opinion of the RTs that are assessing them. They're entering pre-formed teams, and they have to integrate into these teams very quickly. Students are entering clinical practice, clinical placement in an environment where they're often working long hours outside of placement. They're required to bear the cost of placement themselves. And as well as this, they have to complete assignments during placement. All of this they're doing while building their professional reputation. And as I say, they're being ascribed a grade at the end of the placement itself. So it is a highly stressed environment for students to be placed into. And when students are entering clinical education itself, the research shows us that their overall levels of empathy for patients and for their colleagues over the first 3 years of their studies decreases, and decreases specifically quickly during the 3rd year of study. And from there, for the rest of their studies and for their working career, it never recovers. So it drops over the first 3 years of students' training, and then ultimately it tends to stay about the level it finds at that time. And the levels of empathy are really important for healthcare professionals in general, and RT's feelings of professional well-being, and preventing burnout in the RT workforce. And alexithymia, which is the lack of ability to identify feelings in others, and feelings of moral distress, are what negatively impact feelings of professional well-being and of empathy in RTs. So our feeling is here in the discipline. If we can intervene early and give RTs a strong sense of moral identity and personal judgment and reasoning, we will be able to prevent this slide in empathy, and we will be able to increase overall feelings of professional well-being in graduating RTs. And the way we've done this in the discipline, just to give you a quick outline, is we've integrated not just resilience, but moral judgment and reasoning into the clinical placement curriculum. So in the first year, the students are given a resilience and empathy workshop, which aims to instill an empathetic outlook in students. And this session is very different from anything else the students are likely to do during the course. It is highly creative. We get students to make models using clay. And the aim of this is that we're getting students to discuss their personal moral viewpoints from an individual stance. And what we've looked at through the evidence is that if you're able to understand your own moral stances and your own moral principles, your feelings of moral distress are likely to be greatly reduced, and therefore the impact of moral distress on students' empathetic outlook overall is going to be reduced. Following on from this, in the second and third year, what we have done is we have introduced moral judgment and reasoning workshops. And we do this through peer debate. And this is based on research done by two of my colleagues, Maeve Kearney and Claire Poole, along with Cicely Roach from the School of Pharmacy here in Trinity. And their research showed that if students are able to navigate professional moral dilemmas through the use of their own, what's referred to as bedrock schema, which is their own personal values, then their feelings of moral distress, again, are going to be greatly reduced. We've done this through peer debate with the second and third years on the course. So the first 3 years, students are receiving clinically specific education in moral reasoning and judgment, because we want to instill this resilient and empathetic outlook in our students. So thank you very much. I wanted to just summarize by saying that obviously our aim is to produce well-rounded clinical practitioners, and we want to aid them in gaining the clinical skills. And we can do this not just by designing effective simulations in the clinical setting, but also by applying the principles of effective simulation to any clinical task that students and any learner is attempting. Whenever we are supervising students in the attempts at clinical tasks, we always want to make sure that we're providing effective feedback on not just their performance, but how they reflect on their performance. And lastly, we want to produce well-rounded practitioners, I was saying, and if we can instill a resilient and empathetic outlook in our RT students, we will promote professional well-being in our graduating RTs, but we'll also promote the ability for students to take on feedback and for them to attempt clinical tasks in general. So thank you very much. Michelle, back to you.
Thanks very much, Leo. That was great. You touched on a lot of very important topics there, I think, that obviously affect us in radiation therapy education. But as you've been speaking about it, I've been thinking of other professions where, of course, the very same scenarios are going to occur. So I think it's very useful for everybody. I'll have a quick look in the Q&A before I have started my list. You know, I have a list of questions. But while people are having a think, and sorry, just to say again, if you do have a question, if you use Q&A and not chat, please. But while people are having a think, I was just wondering about advice, and you showed the very nice models about giving feedback and now how it should be a dialogue and not kind of a monologue of just speaking at the student and not engaging them in the conversation. But what kind of advice would you have for people in the clinical department where they have to provide feedback that maybe a student doesn't want to hear, and it's quite a difficult situation, so it's contentious, or the student doesn't agree with the feedback, or the student gets extremely upset by what's being said to them? Have you got any kind of, I suppose, practical advice for colleagues where that could happen?
Absolutely. And these are obviously sensitive situations for the RTs. They're often very hard to approach. And I think they can often be quite unpredictable for RTs when they're giving students feedback, which, like you say, might be contentious or just in general might be negative. I think the key thing to do is always just get the student's view on what's occurred first. And then once you've done that, you can start to input your feedback to them. Now, going back to the learning objectives and the expected standards is always the key, because students can find feedback, especially when it's viewed as more negative, they can personalize that. And really what we want to do is focus on the behaviors in comparison to the standards, rather than making it something personal. So not saying you have done this or focusing on you have done this, but here's what you have done. Here's how it's not in line with the standards that we expect of you at this point in your clinical placement. And here's how you can bridge that gap. Now, ultimately, you are the assessor. and you are the what you know your impression of the student's performance on that task is the one which is providing the assessment. And I think there the key is to be direct. And often students, where they feel feedback is contentious, it's because it's not direct and honest enough. Focusing on the key elements of the task being attempted and focusing on how the student hasn't met them, and not surrounding it with maybe your demeanor was very nice, or you put in a lot of hard work, or perhaps saying you're getting there, but you're not quite there yet. Just focusing on the actions is the key.
Okay.
Ultimately, sometimes if students aren't in a position to receive feedback constructively, then it's just simply not a constructive thing to do to give feedback in that environment.
Okay. So the advice then, if I'm hearing you correctly, is be objective, link it back to what is expected, and don't try, as of course, as human beings, we have the tendency to kind of try and soften the blow, because that's just adding ambiguity, if that's what I'm hearing from you.
Absolutely. And students feedback to us all the time that really what they want is honest feedback. And sometimes you can't prevent students getting upset when you give them feedback. But actually, even if they do get upset, they will value being given that honest and direct feedback that's easy for them to understand and easy for them to act on.
Okay, great. Thank you. Very good advice for all of us. Yeah, then I wanted to ask you something a little bit about, because I find the workshops that you have on resilience really interesting. I'm just wondering, do you think that, well, I suppose one of the major issues in radiotherapy practice at the moment globally is retention of radiation therapists within the profession. I'm just wondering about, and maybe this is slightly tangential from your topic, but what is there evidence or anything about students' clinical placement experience? We can start with that one first, and kind of their willingness or their likelihood to remain in the profession, or do you hear that from students even anecdotally, that if they have a really good experience, with good feedback, etc., that they're more likely to remain in the profession? Or do you think that that's a bit of an overreach?
Well, I think students will very closely tie positive experiences in clinical placement to where those experiences took place. So if they have a really good placement in a particular department or a particular part of the department on a particular unit, they will really tie that period in placement to those specific locations. And that will really affect how they view their career. So often people will attend a department that they would have never have thought of working in their qualified career. But once they've had a really good placement in that location, they will really tie it to that location, and that will affect how they view their future career. I think with regards to retention, the research shows that burnout really, really impacts the staff being retained in the workforce. And actually, the burnout doesn't start when staff are working 40-hour weeks as qualified staff. It starts in the first year as a student. The students begin to, feel that burnout process. So at that point, that's why we want to intervene with students and try and prevent that. And actually, the interesting thing is that it kind of levels off when they are students. And what impacts it often is students' lack of ability to impact situations which might be distressing or which might be upsetting for them, because they're not yet clinical decision makers independently in the department that they're in.
Well, I'm just wondering, it's quite interesting about burnout starting just, as students are literally about to graduate, because I mean, I suppose, I'm probably so old that I would never have considered that that would have ever happened, because that's not what we saw previously. I mean, from the resilience workshops, are you seeing that all of the things that you mentioned earlier about what students have to contend with now, with, quite a lot of them are working kind of round the clock between studying, working, traveling, long distances because of issues with rent and nowhere to live. I mean, those kind of, I suppose, nearly fundamental educational issues, they appear to be, are they obviously contributing towards this, along with the professional decision making, as you've mentioned there, towards this kind of, burnout at a very early stage in one's career?
Yeah, well, I think that those pressures, the workshops that we do in the clinical practice modules, they're not really focused on helping students even deal with those pressures. I mean, students do receive resilience training elsewhere from the college, but in particular, what we're looking at is when you're experiencing those pressures, which are already on top of you, and then you're put in a situation where you're required to deal with situations, as we call them, of moral distress, where there are decisions which have to be made which impact patients, but where you're being prevented from taking a course of action which produces the ideal outcome.
Okay.
On top of those pressures, having those situations is what really leads to the burnout. So if we can allow students to deal with those situations when they're feeling these pressures, hopefully that's the resilience that we're providing them with.
Okay, that makes sense. Great. Well, I don't see any other questions in the Q&A, so I think we can wrap it up there for this afternoon then. So thank you very much, Leo, for that excellent presentation, and thanks everyone for attending today. And we hope that we will see you next month, when we will have the manager of the Irish Radiation Oncology Research Group, Roisin O'Mullally, will be with us, telling us about her role as a radiation therapist leading a research program. So we hope you will join us then. But otherwise, have a lovely afternoon, and thanks for joining us. Bye bye.